allergy tests in no way, skin tests cannot predict the possibility of having a reaction. So it's very difficult to exactly pinpoint what caused this allergy.
Drug allergies can affect anyone, and it often goes unnoticed until it becomes serious. So to help us understand the signs, risks and safe management, we warmly welcome Dr. ShehnaazBegum, Pulmonologist and Allergy Consultant to nellikka.life. Welcome, Doctor.
Thank you.
So usually we have heard about these drug allergies. It's very common, but it often goes unnoticed. So for the common people to understand, can you explain what exactly drug allergy is?
Well, a drug allergy is an unanticipated, something that you do not expect, adverse reaction to a drug. And it usually has an immunological mechanism, underlying mechanism to it. So I will explain with an example. Like when we take a salbutamol nebulization for breathlessness, it is anticipated that you have some amount of palpitation or a faster heart rate, and gastritis when you take painkillers, etc. So that is kind of anticipated. That's an adverse event. Sometimes it is an extension of the pharmacological action of a drug. Okay. But drug allergy is not anticipated. You do not expect to have drug allergy. And it has an immunological basis, which means that the cells that constitute your immune system, they identify the drug or the drug plus some protein complex as foreign and mount a reaction against it.
Okay.
So that's what underlies drug allergy.
So, doctor, do we usually see drug allergy when we take the medication for the first time, or in recurring or in repeated intakes do we experience the drug allergy?
Well, that can happen either ways. I mean, there are a lot of mechanisms underlying drug allergy. Usually we have type 1, type 2, type 3, such kind of hypersensitivity reactions. Okay. And drug allergy is not restricted to any particular class. Different types of allergies, they can, sometimes the same drug can have different kinds of underlying allergic or hypersensitivity mechanisms. Okay. So it's usually the Ig mediated variety or the type 1 hypersensitivity, which we sometimes call the classic allergy. And that is the one which requires a sensitizing event. That is, in a sensitizing event, what happens is that the drug enters the body, or any allergen enters the body, and the body's immune response produces antibodies against it. So you need that first event to produce antibodies to recognize it as abnormal and produce antibodies. And from the second event onwards, these antibodies work against the allergen, be it drug, be it anything else, and mounts a response. So that is Ig-mediated allergy. In IgE-mediated allergy, it is very rare that the allergic reaction is precipitated from the first intake. But for other kind of hypersensitivity reactions, you do not always need a sensitizing event. And many times I have heard patients saying that I have been taking this drug for so many years now, and now I have developed a reaction. That can also occur. You can have, the sensitizing event can happen sometimes later. And then you go on to develop an allergic reaction. Even during the first intake also you can develop a reaction.
So doctor, in a place like India, what are the most common triggers that cause this drug allergy, or maybe what are the major medicines that cause drug allergy?
Well, I would put it as risk factors rather than triggers. Okay. Because when a patient comes with drug allergy, it's very difficult to exactly pinpoint what caused this allergy. Okay. So risk factors can be extremes of age. We usually see drug allergies more in a rather elderly population. Okay. And sometimes certain viral infections precipitate drug allergies, like EBV infection or HIV. Patients can have more of drug allergies, and certain kind of genetic predispositions, that is certain HLA subtypes. HLA stands for human leukocyte antigen. It's got something to do with your genetics basically. So certain HLA subtypes are associated with certain kinds of drug allergies. Certain drugs like allopurinol or maybe abacavir or carbamazepine, etc. So that are some risk factors. Those are risk factors associated with drug allergy. And the other question as to which drugs. So world over, NSAIDs or non-steroidal anti-inflammatory drugs, Those are the ones that we call painkillers commonly. We have ibuprofen, we have diclofenac, mefenamic acid, aspirin, etc. So NSAIDs, and then antibiotics, more specifically beta-lactam antibiotics, which includes penicillin groups of antibiotics and cephalosporins. These are more commonly found to produce hypersensitivity reactions. Then there are certain other drugs like neuromuscular blocking agents, which are used in anesthesia. And then you have radio contrast dyes, which are used during your radiological scans procedures and scans, etc. These are all known to cause drug allergy. But having said that, any drug can cause allergy. I mean, no drug is like exclusively safe or, so that does not happen. Any drug can cause allergy. Only thing is that certain drugs are more prone to cause allergy. And another thing is that these drugs are the more frequently used ones. NSAIDs and antibiotics are much more frequently used. So it's natural that you have more propensity or more event of an adverse reaction to those drugs.
Also, doctor, do these natural medicines or this Ayurvedic medicine or traditional medicines cause this drug allergy?
Well, there is a pharmacovigilance database called WHO VG-Base. So pharmacovigilance basically stands for adverse event reporting to drugs. So not just allergic reaction, you can report any kind of adverse events in pharmacovigilance databases. So it based upon the data that is available in the WHO VG-Base, a number of papers have come up, and one of the top listed papers is from India, published from India, from Karnataka. So they have cited a number of adverse events occurring to traditional medicines, and they have listed these traditional medicines as well. So that can range from milder reactions like rash and itching to severe reactions like liver function disruptions, etc. Those have been reported. All kinds of reactions have been reported in this VG-Base, and the incriminating traditional medicines are also listed against it. I think anybody can find it with a Google search. So to summarize, I would say yes, they are also prone to cause reactions.
So, doctor, we mentioned about the causes and the common risk factors of drug allergy. So, is family history or genetics cause for drug allergy?
Yeah, that's what I exactly mentioned in our previous question. HLA association, HLA subtyping. You might have heard of HLA in organ transplantation, etc. So certain HLA subtypes are prone to cause specific drug allergies. As I mentioned, carbamazepine, abacavir is an antiviral agent, allopurinol, etc. They are associated with the hypersensitivity to these drugs are associated with certain HLA subtypes.
So, doctor, we talked about all these causes and all. Now, moving on to the diagnosis. So, what are the common diagnosis methods available, to test drug allergies?
The most important and the first step in diagnosing any drug allergy, I would rather say investigation of a drug allergy, is taking a patient's proper history. So, one thing is that many conditions that a patient suspects or labels as drug allergy may not actually be true drug allergy. So it becomes very important that you filter out what is allergy and what is not, because especially when it comes to antibiotics, generally with all the drugs, a fear of an allergic reaction or an adverse event might actually be preventing them from taking a very precious drug, very necessary drug. So history, its importance cannot be overemphasized. It's so important, and it's actually the most important step. And what you are actually looking at is the symptoms and the drugs that led to this. So it's very important that you know which are the drugs that you took when you had this reaction. Either the patient has to know it, or he or she has to be given this in documentation by the treating physician as to which are the suspected drugs. And it is based on this history that we determine what tests are to be done and what drugs are to be chosen to be tested. So we have skin tests, which is kind of a preliminary step. So among skin tests, you have prick test, you have intradermal test, you have patch test. So prick test, the sensitivity is quite low, but it's a very simple kind of test. It does not draw blood, it does not cause pain. It's just kind of a prick. That's all, with the solution of the drug. And then second step is the intradermal test, where a greater volume of the drug is injected literally into the skin. And because you are injecting a greater volume of the drug, and in case of an allergy, this can actually precipitate an adverse event. So the dosage or the concentration at which intradermal tests have to be done for all of the drugs or individual drugs, that has been well defined by certain authorities, certain scientific bodies, and it is imperative that you follow these concentrations, because otherwise there are a couple of problems with that. One is that the patient is at risk of developing a reaction. Second, it can act as a sensitizing event for the patient, and this can lead to development of antibodies against the drug. Third is that you cannot distinguish true allergic reaction and the irritant reaction, because in high concentrations drugs can cause irritant reactions. So you have to perform this test at non-irritating concentrations, which is very important. Many times the patient may not realize that there has to be such a dilution for the drug. So it is the responsibility of the treating physicians to take care that the drugs administered during intradermal tests are at non-irritating concentrations. That's very important. And then you have patch tests. Patch tests are where drug mixture is kind of plastered or adhered to your skin like a patch. You're just plastering it on, you're just putting it on, you're not injecting it in any way. And this is used in the assessment of delayed allergic reactions. And the reading is also done in a delayed manner. You ask the patient to come back after 2 days and then remove the patch and then see if there is a reaction developed or not. So that's about the skin tests. And having said that, I have to mention that skin tests are not valid for all kinds of drugs, not even for all antibiotics. So you have to, take the results with a pinch of salt in the background of all this scientific knowledge, whether this is valid or not. And then if you still suspect a patient to have drug allergy and the skin tests have come negative, because skin tests can come negative in certain drug allergies. So in such cases, you can proceed with the oral provocation test. And whether the patient is fit to undergo an oral provocation test, there are again a lot of screening criteria and things that you have to take care of. And if you determine that a patient can undergo, then you have to do it under proper medical supervision with all emergency equipment available. And this is usually done in a graded manner. That is, you start with a smaller dose and slowly build the dose. And this is done at regular intervals. I mean, the building up of dose is done at regular intervals, and then you monitor the patient for adverse events, their vitals, etc. So that's what you commonly do. And then you have certain blood tests. We do see patients coming with, blood tests which give antibody levels to drugs, specific IG. So they are said that you can predict reaction to a drug with this. But as I said, not all drug allergy reactions are IG mediated. So IG antibody levels may not actually predict their their probability of having an allergy. And we have certain other blood tests which are under validation, called basophil activation test and lymphocyte transformation test, etc. So when we have these tests, we might actually be able to predict the possibility, because with other tests, no other skin test or anything can actually predict the possibility of a patient or probability to develop drug allergy. They can only be used in the investigation of a already known drug allergy. So basophil activation test, once valid, it is said that it might be able to predict the possibility. So we are looking forward to it.
So, doctor, we have seen many people coming up with the tests of many drugs showing that they have allergies. So, do you feel that it's a valid test?
Yeah, you mean like a list of drugs tested? So, that is, I wouldn't actually encourage doing that. There are a lot of reasons. One, this is like a lot of drugs. Most of the drugs you might not actually be exposed to ever in your lifetime. And these drugs may not actually cause allergy by an IG mediated reaction, because skin tests actually look for specific IG, that antibody alone. And as I said, not all drug allergy reactions are IG mediated. Actually, there are a huge number of allergic reactions which are non-IG mediated. These cannot be diagnosed. And even if you have a positive reaction, it means that you have specific IG against the drug. And presence of specific IG alone does not predict your possibility of having an allergy. It may not always correlate clinically. It only says that you're sensitized. It does not say that you are allergic to it. So to predict the possibility of having a drug reaction if you're doing such tests, I wouldn't really encourage that. And as I said, we do skin tests, but it is for the investigation of a suspected drug reaction. And we test for drugs which have caused the reaction, drugs which may have cross reactivity, because certain drugs have similar chemical structures, like NSAIDs, there's a group. So when you have one allergy to one drug, we usually test to the others also. So antibiotics, beta lactams, we test to those which may be cross reactive. So to assess cross reactivity, you may add the drugs, and then to identify safer alternatives as to what patients could use, to identify those, and to deem a drug safe to use, we do the test. We may even challenge the patient with the drug and see if he develops a reaction or not before declaring it to be safe to be used. So that is how we use the tests. And drug allergy tests cannot in no way, skin tests cannot predict the possibility of having a reaction. So you cannot just go and get a drug allergy test done and say, I have all these positive, I am allergic. It does not mean you're allergic. The positivity does not mean that you can develop a reaction. And when it is negative, it does not assure you that you can never develop a reaction. You actually can.
Yes. So doctor, we talked about all the risk factors, treatments, diagnosis and all. So can this drug allergy be cured permanently? Is there a permanent cure to drug allergy?
Permanent is difficult, but we can desensitize. And desensitization is done in cases where this drug is very essential. For example, aspirin. Aspirin is very commonly used in cardiac indications. And if the patient requires aspirin, and unfortunately if they are allergic to it, we can perform desensitization. So desensitization protocols, slow, fast protocols are available. We do it, and it depends upon what dosage the patient actually needs. Some patients need 75, some need 150. It depends upon the cardiologist's decision to what dose they have to be desensitized. So we desensitize the patient to the appropriate required dose, and they can then continue to take that dose. So, but desensitization is not permanent. If they take a break, like it's usually said that if you have to stop, it has to be like less than 48 or 72 hours. If you break for more than 3 days, your desensitization that might be lost. You might again be sensitive. So you have to start all over again. Yes. And desensitization protocols to certain chemotherapeutic drugs for treatment of cancer, that's also done.
So doctor, one last question. We usually take this paracetamol and all when we have fever. So there are conditions where the patient cannot consume at least these kind of painkillers. So what is an alternate, or what exactly you would like to tell those patients?
Okay, you mean those who fear that they may have an allergic reaction to any kind of drug that they take. Yeah, certain patients do come with such a history, saying that I cannot take anything, I throw a reaction with anything.
Any drug.
So while you can develop a reaction to any drug, developing a hypersensitivity to a wide class of drugs, huge number of drugs, that's a little unlikely, not very common. So, most of the times, the symptoms that patients interpret as drug allergy might not actually be drug allergy. So, it becomes our job to filter out these symptoms, to filter out what is allergy and what is not allergy. And if there are definitive symptoms of allergy to any particular drug, you can investigate, as I have already mentioned, with skin tests and provocation, etc. And you can look for safer alternatives also. And in most of the cases, we have been able to find safer alternatives for most of these patients. So that gives some peace of mind to that patient that they have some solution when they have a problem. So again, the history taking is like kind of very important. It is actually the most important thing. So it depends upon what kind of symptoms, the timing, the chronology of the symptoms, etc. that you test with, that you determine whether it is allergy and not allergy, etc.
Thank you, doctor.
Thank you.
Today's session reinforces how important is awareness for our daily health and why expert advice matters. And nellikka.life always promises on sharing credible, expert-led content for everyone. So please do like, share and subscribe for such informative contents.